Good afternoon, everybody. This is Mike Lewis with HealthMonics, bringing to you our second practice sustainability webinar with our friends here at Chirpy Bird with Robin Roberts and Joy Rios. They will be walking you through telehealth medicine and the changes with COVID-19. For your convenience, the handout of the PowerPoint presentation is located at the bottom right-hand corner of your screen, as well as there is an area to ask questions. As for the questions, we'll have time at the end to go through all of the questions. If we do not get to every question, we will be reaching out to you through email after the webinar. Our only request for questions is that with regional questions about a specific insurance, that you reach out directly to Chirpy Bird after the webinar, as information about individual regional insurance plans is not available on a large scale basis for us to review at this time. So without further ado, I would like to introduce Robin Roberts with Chirpy Bird. Welcome, Robin.
Thank you, Mike. Thank you for allowing us to talk with your audience today. As stated last week, we all know these are unique and uncertain times, and just like we went through some of the financial options that are available, today we want to talk about some of the most recent changes in telehealth and important considerations and details about leveraging that to help sustain your practice during this time. As Mike said, I'm Robin Roberts. I'm also joined by my esteemed colleague, Joy Rios, 5-time Quality Payment Program author and health IT subject matter expert. Together, we run Chirpy Bird, Inc., where we help practices translate the complexities of various subjects, including things like telehealth, to break that down into easy to understand steps and help you realize how you can deliver great care to your patients and realize the revenue that comes with that. Our agenda today is going to quickly cover the what and why of telehealth and where we stand today, solution options that are available to you, and some important considerations. 2 important nuances within telehealth, that is HIPAA and consent. We're going to cover workflow and office-specific considerations, and really the nitty-gritty of how this is done and how you ensure you get paid, which is going to include the coding option, documentation of a visit, and some things you might need to think about. And of course, we're going to cover some of the more integrate and detailed and up-to-date information regarding billing and reimbursement for both Medicare and several commercial payers. So we have a lot to cover. Let's get started. The term telehealth includes a broad range of technologies and services to provide patient care and improve delivery on the whole that allows for patients to receive remote healthcare services. It involves the use of electronic communication and software to provide clinical services to patients without an in-person visit. That is the whole premise of this. It's frequently used for follow-up visits, management of chronic conditions, medication management, specialist consultation, and a host of other clinical services that can be provided remotely via secure audio and/or audio connections. So why does this matter now more than ever? Of course, in uncertain times like these of the COVID-19 pandemic, telehealth serves unique purposes, like the ability to deliver care to a patient that may be afraid of public exposure or be at high risk. Telehealth allows these individuals to seek care remotely without leaving their home. Likewise, it also serves to better protect the practice physicians and the care team members and your office staff themselves by limiting their exposure to a potentially sick or even asymptomatic patient. However, there is longstanding value for patients right now and even beyond the pandemic, and that is, of course, that they're saving time and money spent on commuting to doctors' offices. We might even be removing transportation barriers for accessing care for certain patients or populations. It just simply makes seeing a medical physician or provider easier and more convenient. It can even increase access to communication with the care team using these remote means. For patients with chronic conditions, they can seek care more consistently from the comfort of their own home. So And of course, in underserved or rural areas where care might typically be unavailable or there's long wait times, telehealth can be instrumental there. So more important than ever, in these uncertain times, if you're not delivering telehealth services or you feel you aren't fully leveraging them at their latest policy changes that have been lightening requirements and increasing reimbursement in some cases, we are hoping that you will consider pivoting with us today, not just for meeting short-term needs, but for the potential to realize how you might leverage telehealth long-term. So telehealth remains a strategic focus as healthcare organizations look to increase patient satisfaction, expand their practices, and grow revenue. But there are countless solutions on the market, and making the right decision can really be the difference between success and failure. So as you look to launch or expand telehealth, let's cover some factors that should be on your checklist. Before we even begin, I would encourage you to think about your long-term and short-term strategic priorities here. If improving patient experience is a top healthcare priority for you, or increasing physician productivity for better time management, are we maybe looking to improve health results for chronic care patients or reduce costs, or just attract a new patient demographic? All of these factors can determine what type of solution you might go with. There are typically two types, and that is EMR or standalone. The distinct advantage of an EMR telehealth solution is typically its holistic integration into scheduling, possible patient consent, and visit documentation. You should know that most EHR solutions do require a patient to have an active portal login to facilitate such visits. If this is something that's challenging for your practice today or something your patients aren't adopting, this may not be the best solution for you. But on the other hand, using the wholly integrated solution may save time and be advantageous in some ways for documentation. A standalone solution is exactly that. It, in essence, is providing a virtual exam room and mechanism of communication for audio and video with patients. These solutions are often easily launched via laptop, tablet, or phone. Some even integrate a pre-visit consent for the patient and can be lower cost than EMR solutions. Additionally, if you're looking for what I'll call expanded reach and revenue option, that is to provide clinical service to patients that are not already part of your practice but require attention and allows you to capture some additional revenue, there are standalone solutions that do only that. But regardless of which solution you try to go with, there are some questions that you should really ask any vendor. Do you integrate with an EHR? How much does any sort of integration cost? What changes would you maybe need to make to your network to accommodate their services? What type of customization features exist? How do they manage connectivity issues? And in today's day and time, that's a big deal. What backup plans are in place should you experience downtime or connectivity issues? And then also HIPAA. What are their compliance with HIPAA rules and where they're applicable? What about security? Maintaining patient privacy. Are patients able to provide consent on the platform? How does the service manager of that standalone solution maybe authenticate and authorize people? And of course, pre-launch support. Do you support the training? Do you support the staff? What options are available for your patients when it comes to training and support? You should make sure that the end users, both in the office and your patients, are well supported. So ask the prospective vendor to help you understand what each of their features and platforms specifically entail. If there's an emergency or things aren't going well for your patients, how easily are you able to exit that contract? So fully understanding the features, constraints, and the type of system you have is really important. HIPAA considerations. I would be doing you an absolute disservice if I did not address the current state of HIPAA during the pandemic specific to telehealth. The Office of Civil Rights and Department of Health and Human Services is responsible for enforcing certain regulations under HIPAA, as many of you know, and they have made some recent changes. During the COVID emergency, which also constitutes under these rules a national public health emergency, covered healthcare providers subject to HIPAA rules may seek to communicate with patients and provide teleservices through remote communication technologies. Some of these technologies, in the manner in which they are used by HIPAA covered healthcare providers, may not have fully complied with the requirements of HIPAA rules. So OCR, the Office of Civil Rights, decided to exercise some enforcement discretion. It will not impose penalties for non-compliance with the regulatory requirements under the HIPAA rules. This means if a provider would like to use other solutions like FaceTime, Zoom, or Skype, non-traditional platforms, they can do so without worrying about penalties being imposed for non-compliance with HIPAA rules. So, for example, a covered healthcare provider that wants to exercise professional judgment to examine a patient exhibiting COVID symptoms or even a non-COVID patient using a video chat application can do so without worry. This is something that hasn't always been the case. So under this notice, covered healthcare providers may use popular applications that allow for video chats, including Apple FaceTime, Facebook Messenger, Google Hangouts, Zoom, or Skype, without risk that the OCR might impose a penalty for non-compliance of HIPAA rules. This is all a good faith provision, ladies and gentlemen. This means this is a short-term rule. I will also call your attention to the fact that there are explicitly in telehealth, there are things that are not allowed. Facebook Messenger is allowed, but Facebook as a platform outside of Messenger is not. TikTok, other social media options where you might be able to exchange synchronous or asynchronous communication, there are still some do's and don'ts. But this opens up a really good opportunity to further connect with your patients on one of these other platforms, even if you're not using one of the EMR or standalone solutions that might typically be used for telehealth. So telehealth workflow, just like any other visit, we need a workflow for this type of visit because it's unique. Just like a new patient visit has unique nuances, just like a procedural visit has its unique nuances, or a therapy visit of different types. Telehealth is a unique visit. And so we've broken down the workflow into 3 components: pre-visit, day of visit, and post-visit. And I want to walk you through the pieces and some of the considerations. Identification and visit type scheduled. It's really easy to tell a patient we want to do telehealth, but if your office right now is seeing patients in person and telehealth, and our schedule doesn't have that kind of visit type, you can imagine quickly labeling the patient a no-show at the front desk, where the doctor expecting to see them in the back is going to cause some confusion. And along with the pre-visit, telehealth education and communication. Everyone on this call probably knows what telehealth looks like for them. They know what it looks like. You're being inundated with information about this stuff. Most patients have not done this type of interaction with you. They have to understand what to expect, how that information will come to them, what they still need to, quote, bring to their appointment, and how they're going to be contacted and how this is all going to work. Even benefit verification is still a thing for this type of visit. So you need to be very mindful of those components even before we interact with the patient. And then the day of the visit, the patient clearly is not going to come check in at a physical window. How do we get the patient checked in if we still need to verify benefits, collect a copayment? How is that going to flow through your office? How will we update insurance and demographics? You'll hear in a little bit that we need consent for telehealth. How will we obtain and document that? And if that has to happen during the check-in process, it's important we understand that. And then the virtual room or digital connection, will that be established by the front desk and passed back to nursing support staff or the doctor? Or is that something the front desk will do to, quote, room the patient? And then, of course, the physician conducting and facilitating the visit and the documentation. But even beyond that visit, once the visit is over, if a prescription needs to be called in, if there's a lab that needs to be run, if there is a big adjustment in care that requires additional facilitation, how might the physician hand that back to the appropriate staff member to follow up? These are all things we need to think through. And then subsequent actions. What if they want a follow-up visit? What if we can't actually deal with the patient's complaint and they need to come into the office? And then, of course, billing and claims adjudication specific to post-visit, and making sure everything goes out the door right so that all of our efforts that have been done through this workflow certainly haven't been in vain. So doing this is no small feat. We need staff support and buy-in. We need to identify the people in the office that are going to help go through this workflow, mitigate any of their concerns, but make sure they're apprised of these operational process changes. When will telemedicine visits occur? Do you want your staff scheduling them any day of the week? Are they on demand? Is there a dedicated room that's going to happen in where we are going to keep a specific PC or laptop? It's really important that the staff are properly trained on the telemedicine workflow and are comfortable with this service offering. And then lastly, marketing it to patients. If it is your long-term goal that this process and flow be something that you deliver on an ongoing basis, which can be greatly advantageous to your practice, we need to make sure that the patients know the service is now offered and make sure that they're up to speed, just like you are, about what telehealth looks like and how it works. Education and communication of expectations is key for patients and ultimately the telehealth success and its workflow. So before we start getting into some more of the details, I want to talk about some tools and resources to facilitate telehealth. And some of these things might go without saying, but you'd be surprised how many people kick off telehealth without it. While many of the solutions are made to be as simple to use as possible, think Skype, but with complete security and extra features that health professionals need, like the e-prescribe, visit documentation, billing, it's always helpful to make sure we've gone over kind of a virtual or technical checklist to make sure we head off any potential problems. So I'd like to offer some simple but often overlooked tips that can help make things easier. Make sure you have a high quality webcam. The doctor might be using his laptop, but if that laptop is from 2002, you might find that it's not easy to clearly see the patient's face. And when the patient can clearly see you, they're going to be more comfortable and respond more positively to the visit. You don't need to go out and buy a super fancy camera. Really easy to access a high quality webcam. Number 2, test out all of your equipment before it starts. Practice with your staff members in your office, your billing team. Call someone, call your mom, call your sister, call your brother. Practice, practice, practice. You can make sure the video is clear, the audio is clear, and it's going to help you get your workflow down pat. Test out your microphone and speakers even when you're doing this. Can they hear you? Or maybe like me, the doctor's speaking really loudly, really close to the mic. Maybe it's really awkward. We're getting feedback because the space is very empty. Assess these things now. And then set up your camera at eye level. I'm sure many of us, especially over the last several weeks, have all been victim to somebody that has the camera facing up their nose, right at their forehead, right into their neck. Make sure that if you're using an integrated or external camera, that it's set up appropriately so it's easier to maintain eye contact with the patient and they're going to stay more engaged in the visit. Close unnecessary programs to make sure you have plenty of bandwidth. If you can get a wired internet connection, consider that. And then if you can, plug in your mobile device. I was guilty of this last week at the very last minute on the webinar. My own laptop went dead. How embarrassing. We certainly wouldn't want that to happen with a patient. And find a quiet space. I will tell you, yesterday I had a telehealth visit with my internal medicine doctor, and there was a doctor on either side of them having a visit. It made it nearly impossible to have a good, clear interaction. I think I learned more about what the provider to the side of him was doing with their patient than I was able to focus on the delivery of what the doctor was trying to tell me. It's just a really big distraction. So adjust your lighting if you need to. If you're in too bright or too dark of a space, it's of course hard to see. And also follow the same clinical guidelines as you would if you were in person. Even if you can't do a physical exam, we can ask good questions to take a thorough history of present illness. And so while the technology and interaction is different, those same key clinical guidelines apply to a virtual visit the same as a physical appointment. And lastly, stay engaged. Treat the virtual visit like you would an in-person. Try and maintain eye contact or nod along to make sure they know you're listening, because you're not there, and those physical cues, albeit virtual, are sometimes hard to pick up on. The next thing I want to talk about before we start to get into some more of the nitty-gritty is a really key component, and that is patient consent. In telehealth, informed consent is used to explain what telehealth is, lay out expected benefits and possible risks associated with it, and explain security measures. It often requires a written form which needs to be signed by the patient and or orally acknowledged and is noted in the patient record. I also want to let you know, getting your patient's consent could be a legal requirement in your state or a condition of getting paid depending on the payer you're billing to. To check what the requirements are in your state, there is the Center for Connected Health Policy website. Again, I'll say that Center for Connected Health Policy's website. They have a state map that allows you to easily click on your state, scroll down to the section labeled consent, and you can see whether state laws require you to get patient consent and if there are any corresponding requirements specific to even state Medicaid programs. Some states don't have any state requirements. Others require verbal consent. Still others require physicians to get written consent and store it in a patient's record. And so while getting a patient's consent for telemedicine may not be a requirement of your state, it is still by ATA standards, the American Telemedicine Association's suggested best practice to put one in place. So what kind of information should you include in your consent form? Well, ATA suggests that we inform their patients of the rights when receiving telemedicine, including their right to stop or refuse treatment. We have to tell the patients their own responsibilities when receiving telemedicine treatment, have a formal complaint or grievance process to resolve any potential concerns or issues that might result, describe the potential benefits, constraints, and risks, like privacy and security of telemedicine, and inform patients of what will happen in case of technology or equipment failures during a telemedicine session. And so that involves having a bit of a contingency plan when the tech fails. In addition, you may want to consider outlining some of your basic telemedicine program policies around billing, scheduling, cancellations. Also remember, in cases where the patient is not competent and does not have capacity to give consent, consent should be obtained in the same ways as a face-to-face consultation. That means the physician may have to arrange for consent to be given by a family member, friend, or care partner who has the requisite legal authority, for example, guardianship, to give consent on the patient's behalf. If you are going to do telehealth, this is one of those showstoppers that you need to understand before you can continue. If you're billing again through Medicaid or a payer that has a template patient consent form, you may want to consider using that form as your standard. But in most cases, it's up to you to decide to what to include. We've provided an example here for reference. Again, please know that state or payer-specific policies may apply, so you should seek guidance in developing a comprehensive and compliant consent script or a document. And remember, verbal consent can also be obtained, but we should always adhere to a consistent and documented script, even in the event of obtaining it verbally. All right, documentation of a telehealth visit. Documentation of the visits yourself are predominantly the same as a face-to-face encounter. The information of the visit, the history, review of systems, consultative notes, or any information used to make a medical decision about the patient should be documented. Best practice suggests that documentation should also include a statement about the service that was provided through telehealth, both the location of the patient and the provider, and the names and roles of any other persons participating in the telehealth service as part of the care team. Lead the visit as if the patient is in the room, except, of course, we have a limited physical exam. For example, the patient can show a scar. They can push on the skin to demonstrate edema. And a physician's clinical skills and knowledge is going to tell them if a patient is not looking well or looks ill. We've even seen physicians ask patients or family members to help them capture pulse, respiratory rate, while the physician counts in a video chat. We've also seen hypertensive patients be asked to take their own BP at home if they have a device and are asked to show the reading on the screen during a telehealth encounter. We also want to share with you a link to a CME telehealth course available through Jefferson University Hospital. Please know that there is no business conflict to disclose here with this recommendation, only that we've worked with numerous physicians who have taken this course and shared that they themselves found some useful suggestions and materials and ideas that they've implemented as early as the next day. While it does cover a lot of basics, it does give a lot of great clinical examples that can be used by a physician or a clinician. Again, documentation required for telehealth can vary by state, but again, you should be documenting the same as if you were face-to-face. So for example, let's take a little bit more of a clinical vignette look at an objective component of a basic SOAP note. We've provided an example here, but let's say we have a patient who's been having sinus congestion and fever for the past 10 days and they're getting worse. The patient shouldn't deny shortness of breath, but he's been having a cough and he's tried OTC medication like NyQuil and ibuprofen. So, objective. You may not be there to do the exam on the patient, but you could definitely consider writing something like the following if you're able to assess and observe it. Patient is speaking in full sentences. Mood and behavior seem appropriate. No signs of distress and no wheezing heard. Audible congestion in his voice. He's coughing on the phone. You might even take it a step further and consider saying that the patient's able to move their neck in all direction without pains, or that we observe them walking normally. There are things that can be captured remotely and virtually, and if you can, do your best to document them. But again, I would consider that course. It's a great way to earn CME credit about something relevant and get a comprehensive overview of clinical documentation, which is so. All right. Let's talk about how we begin to get paid for these efforts. We really want to cover the coding and billing details. And before I dive into this, I want to tell you about some of the latest updates by CMS. CMS lifted Medicare restrictions on the use of telehealth services during the COVID-19 emergency. Most of these key changes are effective March 1st, and they are lasting throughout the national public health emergency. Some of these updates include that Medicare will pay physicians for telehealth services at the same rate as in-person visits for all diagnoses, not just those related to COVID-19. This means that telehealth is offering full parity in payment to physicians. Patients can receive telehealth services in all areas of the country and in all settings, including at their home. CMS expanded the list of eligible telehealth services, and you can find a link to that on their website. We're going to deal with 4 main types of them today, but they are extensive. The qualified healthcare professionals that are eligible for telehealth has been expanded, and additional codes for services related to them have also been added to that telehealth list. CMS has also clarified that telehealth services are permitted for both new and established patients. As you will see, physicians can reduce or waive cost sharing on telehealth visits, and physicians licensed in one state can provide services to Medicare beneficiaries in another state. However, state licensure laws do still apply. So let's take a look at the 4 types of telehealth and virtual care options that are most applicable to current circumstances and that most of the people on the phone with us today will probably be using. The first and most common type of telehealth services include exactly what we'll dub telehealth visits. These are E&M codes. You guys know these well. These are office or other outpatient visits. In line with this, you have the G0425 and G0427, the telehealth consults for emergency department or initial inpatient. We also have G0406 and G0408, the follow-up inpatient telehealth consultation furnished to beneficiaries in hospital or skilled nursing facilities. The next thing is what is called virtual check-ins. This is for established patients, and this can happen in a couple of different ways. This can be any real-time audio, think telephone, or two-way audio interactions that are enhanced with video or other kinds of data transmission. If an E&M service is provided within the defined time frames, then a telehealth visit is bundled in that E&M service. It would be considered a pre or post visit time of the associated E&M service and thus not separately billable. So please know that the check-in is best done and billed by itself. There are no geographic restrictions on patient location for virtual check-in, but it should be initiated by the patient. We are not cold calling to solicit a virtual check-in. Verbal consent to bill and documentation of a virtual check-in is required. And again, communication can use non-HIPAA compliant technology during the public health emergency. So that HICPIC G2012 and G2010 are a great way to touch base with your folks during the COVID emergency, but note that that emergency guidance is only extended for the pandemic time frame. Let's talk about e-visits. This is for Medicare patients that may have non-face-to-face patient-initiated communication with their doctor, of course, without going to the office, by using online patient portals. Patients must generate the initial inquiry and communication, which can occur over a 7-day period. Patients must verbally consent to receive virtual check-in services. So the service time with these codes, which are 99421 and 99 through 99423, are all dictated based on time. So if the patient initiates a call to the physician's office, this would qualify the CPT 99421 and 99423 are all based on time. This is an online digital evaluation and management service for an established patient for up to 7 days, where we add together the cumulative time. This can be a great way to connect with patients who are already online in your portal and check on them over a period of days and bill based on time. Telephone only. This is something that has come back online and is a great way to see reimbursement for personally participating in telephone-only calls for discussing or coordinating care. And so there is a series of codes, 99441 through 99443, where 99441 is for 1 to 10 minutes, 99442 is for 11 to 20 minutes, and 99443 is for 21 to 30 minutes. These are codes that when talking with a patient by phone, you want to make sure you're documenting service that includes the date, the participants of the call, the length of the call and visit, the nature of the call and visit, and all medical, vocational, or other medical decisions made. It's also important to note that psychiatrists and clinical psychologists may only bill for these services when also providing consultation or evaluation. So if you are only able to get a patient by phone, let's say you have a telehealth solution that is absolutely failing, 99441 through 99443 can be a great way to make sure you get some type of reimbursement. So other than billing, one of the biggest questions we get is, which code do I use? And one of our favorite resources to answer that question is the flow chart you see here. It makes the decision very simple. The answer to knowing which code to use starts with a cursory question about how you are connecting with the patient on the left-hand side. Do you have video audio? Are you connecting to see if an E&M visit is needed, or are you communicating just by phone? From there, if you do have video and picture, is the interaction happening in real time? You can see as you answer the questions on the left-hand side, it leads us to answer the what of what type of visit to select based on the visit types we just reviewed in the previous slide. From there, the physician in office can decide which code within that visit type is accurate and appropriate to bill based on time spent, medical decision-making complexity, scope of service provided, etc. So once you have decide on a visit type and code, what can you expect in terms of reimbursement? Using the 4 visit types, we have displayed those for you here. In its latest moves to expand telehealth adoption during the pandemic, the number of services that can be delivered, as you've heard me say, is quite vast and continues to expand. Moreover, CMS and Medicare are providing payment parity to physicians on these services. Telehealth visits include emergency department visits, initial nursing facility and discharge visits, home visits, therapy visits. But like I said, we're dealing with just 4. So here you see the 4 different bucket types of visits: telehealth visits, virtual check-in, e-visits, and telephone only. And if you look at the reimbursement, I would like you to note that this range includes the high-low of facility and non-facility rates, but is always subject to your MAC locality and your personal contract. But these are the expected and anticipated ranges of payment you can expect to receive for the delivery of these services based on, again, where you are and what your contract says. Billing Medicare. The policy and payment landscape around telehealth remains complex. As the country is navigating this pandemic, change is happening rapidly to expand these services, and Medicare can pay for office, hospital, and other visits furnished via telehealth across the country, including in the patient's own place of residence, starting March 6th. Prior to this, Medicare could only pay for telehealth on a limited basis. So, again, you can see we're talking about 3 main types of services. And so let's take a look at what you need to do for the Medicare telehealth visit. If you are delivering an E&M code for a Medicare telehealth visit, the provider must use interactive audio and video telecommunications that permit real-time communication between the distant site and the patient home. Distant site practitioners who furnish and get payment for covered telehealth services can include physicians, nurse practitioners, physician assistants, nurse midwives, CNAs, clinical psychologists, clinical social workers, registered dietitian and nutrition professionals. It is imperative, of course, that you bill this appropriately. So please note that if you are billing a Medicare telehealth visit, as you see the codes listed there, the place of service, for most of us, if that's an office, would remain, say, 11. The only modification you will make to billing that to indicate to Medicare that this was a telehealth furnished service under those guidelines I just talked about would be to add a modifier 95. That is the most recent guidelines. And again, payment parity exists here. Virtual check-ins. In all areas, established Medicare patients in their home can have brief communication service with practitioners via a number of communication technology modalities, including synchronous discussion over a phone or exchange of information through video and imagery. And these virtual services are to be initiated by the patient. Medicare pays for these virtual check-ins for patients to communicate with their doctors and avoid unnecessary trips to the office. Doctors and certain practitioners may bill for these virtual check-in services furnished through communication technology modalities using G2012 and G2010. Standard Part B cost sharing applies to both. Very important to know there. So some of the details around the billing of that G2012 documentation requirements as an example. You have to verify that you've confirmed patient identity, ergo name, date of birth, other identifying information, details of what occurred during that communication, like patient problems, details of their encounter, document the nature of the call and why it was not tied to a face-to-face visit or procedure that occurred within the past 7 days, and document that a subsequent office visit for the patient's problems were not indicated within 24 hours of the next available appointment. And again, we want to make sure the patient has consent. So virtual check-in, the G2012 and G2010 are both options for you. Some important updates as recent as April 13th. Both G2012 and G2010 may be billed by the same physician for the same patient on the same day, as long as the requirements for both are met. Additionally, residents can furnish telehealth services for the duration of the public health emergency under direct supervision of a teaching physician when provided by interactive telecommunications technology. Very, very important. Lastly, e-visits. In all types of locations, including the patient's home, and in all areas, not just rural, Medicare patients may have non-face-to-face patient-initiated communication with their doctors by using online patient portals. So again, you have 99421 through 99423, where those services can be provided using portal communication based on time over a period of 7 days. The only nuance here is that 95 modifier on E&M services. Telephone only, you heard me reference the 99441 through the 99443 can be a great safety net if technology is failing you with Medicare. So what is this and what are the rules of the road? Will telephone evaluation and management service by a physician provided to a new or established patient, parent, or guardian not originating from a related E&M service provided within the 7 days, nor leading to a service or procedure within the next 24 hours or soonest available appointment has to occur. This means that, let's say we're on the phone with the patient today, we're on for 25 minutes, but they end up in your office in the next 24 hours, you cannot bill that phone visit. And the patient has to initiate this request. You can let them know of your willingness to perform this service. We can call them and let them know it's available, but the patient has to initiate it, and they should be notified there is a charge for this treatment. So in the documentation that you have in the PDF, you'll see there are some clinical vignette examples. And I want to be swift in addressing this. Commercial billing guidance. United Healthcare, Aetna Medicare Advantage, Blue Cross Blue Shield, and Humana Medicare Advantage is listed here. We are providing you a grid by service type, including some of the therapy details and hyperlinks about what you need to do when using that service for certain patients and beneficiaries based on the plan you're in. You will see that the biggest caveat remains an appropriate 95 modifier on certain Medicare Advantage and Medicaid E&M visits. The other thing that you'll see is that, for example, Blue Cross Blue Shield on a telephone visit is asking for a CR modifier. You are actually using an E&M code with a place of service 02 and a CR modifier. That's one of the most unique ones. So I strongly encourage you to take a look at these specific payers. This is the latest guidance as of the 13th. And we've even expanded beyond that in continuing to look at commercial billing guidance I want to share with you this grid that comes courtesy of AAFP.org. It is their breakdown of payer and out-of-pocket costs, coverage, parity, and associated in versus out-of-network details when it comes to delivery of telehealth. Note that while the first line is specific to COVID-19, subsequent lines do include details for non-COVID services. For example, you can see that Humana is waiving out-of-pocket only waive out-of-pocket costs on COVID-related visits for an out-of-network provider. It is key that you take a look at what each payer is looking for and make sure you are getting it out the door. Before we open it up to take questions, I just want to say that the one thing I would encourage you to do is as you're billing this and sending it out the door, there are so many telehealth options and buckets these can fall into. Do not settle for zero. If you are adjudicating a claim, review the guidelines of what was delivered, and if you fall into one of these buckets, send it back out, resubmit it, make sure you are being reimbursed for your time and efforts. Additionally, this guidance with CMS and commercial billers is not intended to last indefinitely. Right now, all of the guidance you're getting is the latest we can bring you, but is also set to change and may not last beyond the pandemic. So to supplement our presentation, I'll close before we open it for questions to say we want to share a multitude of reputable links that offer additional guidance and information you may find helpful. Remember that it can change. It has not formally been extended for an indefinite period of time, and to be sure that you check with any of your regional payers and especially your state Medicaid for their specific guidance today and in the weeks and months to come. Mike?
Sure. Thank you very much. That was very informative. Really appreciate that, Robin. We don't have a terrible ton of questions, and a lot of them seem to range around the same things. I did want to start off with one that seems to come in a couple times on this, and that is we haven't had a telehealth policy in the past, and now we're getting plenty of calls that fit that type of policy. How do you recommend starting this up? How do you do it right now?
So if I were to do two things right now, I would assess cost and solutions available from an EMR vendor if you have it. Otherwise, I would take a look at some of the other platforms out there. There's Doxy.me, UpDocs, Doximity is a free app, and I have no personal connection to any of these, nor does our organization. There is a myriad of solutions available. I would look at the top three based on compatibility, right? Because everyone's got different phones. And if you think iPhone and Android are it, you are sorely mistaken. If you think everyone uses the web browser, you would be sorely mistaken. And so I would assess pricing. I think you will find that there is a great disparity between the two, and I would pick one. In our experience, UpDocs is one of the most user-friendly, but I have docs that love Doximity just on their iPhone, but it's not compatible with Android. So and Doximity, I believe, is free, if I'm not mistaken, from the App Store. But I would call and look at that. A lot of EMR vendors do charge a fee for the module. Some of them even charge for clicks or time, which is crazy. And I would pick one, and I would do some practice visits or ask them for a sandbox to do a practice visit with some staff members and see how it goes. And along with that, of course, you need a really strong consent. But practices should not be afraid to do this. All it is a virtual exam room, and I promise you, after you do it a handful of times or two handfuls of time, it will become second nature. You'll just have to figure out how it fits in your day if you're still conducting in-office encounters.
Great, thank you very much, Robin. A couple people asked about some of the websites that you went over. You will be getting them in an email from HealthMonix in a little bit later this afternoon. But one person asked what the website was for the telehealth, the Thomas Jefferson one.
Yeah, absolutely. So I believe it's jefferson.edu. And Joy, if you're on, if you'll just confirm that for me, I believe it is jefferson.edu. But if you search Jefferson University Hospital telehealth, some of the top 2 results in Google are exactly for their telehealth course for physicians or telehealth facilitator. You want the one for physicians if that's what you're looking for. And I suggest going there to check it out. It's not a must, but if you have dove in head first or you're struggling with documentation and how the heck to conduct a virtual visit, it is a great tool. But Mike, we'll make sure you have that and the other couple that I mentioned.
So this is Joy, and the website is cme.jefferson.edu, and the name of the course is Telemedicine Conducting an Effective Physical Exam. The cost is $100.
Thank you.
The other question we had on that was the website for the consent website. Do you have that available too as well, Joy?
Yeah, absolutely. We can definitely get that for you. So it is the Connected Health Policy website, and they have, we will definitely make sure we share that out. It is a great state-specific place to find information. As we referenced, you can just go to their map, and I'm pulling that up right now, Mike.
I've got it up in front of me. So if anybody's just looking at what to Google, instead of me typing it all out, you would be looking for the Center for Connected Health Policy. And so their website is, the acronym of that. So cchpca.org.
Sure. Here's another question here. Following up on, is the start and stop time required, or can the total time cover this? Not sure where they're going with that, but maybe you will.
I recommend if you're doing an E&M, that's totally up to you. Obviously, you want to use the combination of what you do to determine the level, right? When we're talking about physical exam and review of symptoms or review of systems, those sort of things versus time. Up to you decide on those E&Ms based on the current standards you know now. But if you are talking about an e-visit or telephone only, if you want to be thorough, I strongly encourage putting a start and stop time. Also, with all due respect, what we find a lot in our experiences is that physicians and providers especially are undershooting the amount of time. They think it's 15 minutes, but the reality is they're on for 22. And so to make sure you're accurate and appropriate in reimbursement and documentation reasons, I like start and stop.
Great. There's a number of questions on quality metrics and when it comes to MIPS reporting. And I wanted to share with everybody that we'll be doing a webinar towards the end of next week in regards to what measures can and cannot be done through telehealth, as well as if you go to our webpage, mipspro.com, you'll be able to see what measures are available for telehealth. And yes, you should be collecting your quality data for all of these visits that you're seeing these patients through telehealth.
Absolutely. Quality is still king. We know that. And so we're excited to hear more about that next week as well.
Great. Are E&M visits limited to visits per week?
That's a great question. So you should know that historically, there was, even when we were talking about established patients only, that CMS had put a limitation on number of E&Ms during the course of a period of days. That is not a thing at the moment. So if we need to see the patient on Tuesday and then we're doing a follow-up on Thursday, that is okay via telehealth at this point in time. Whether your commercial payers entirely recognize it, I would hate to make a blanket statement that they do, so I would encourage you to check with them. But CMS has lifted that.
Great. Do you have any suggestions on how you would communicate that you'll now be billing for things that were free yesterday or last week?
Oh, yes, absolutely. This is a great question. And that is why, like we had the thing from Ross and friends up there on time to pivot. Guys, if you want to leverage this now and going into the future to make your lives easier, your patients' lives easier, I am totally projecting here, but I anticipate that components, parts, if not a lot of this policy, especially the parity payment, is going to continue. Now is a better time than ever. And I think we are so hesitant to do this, Mike, and I think Joy will agree too. When we're having this interaction by phone, there's a couple of misnomers. One, the patient thinks it's a courtesy, right? Like old school.
Right.
kind of practice of medicine. And two, sometimes it hasn't been tangible. You know what? Here is a great time because people are being inundated by their insurance companies, by Medicare Advantage. You know, I even got a letter from Aetna 2 weeks ago. They are telling me to use telehealth. Well, what a great time to sit down and say, look, Blue Cross wants us to deliver virtual care. Aetna, Humana, Cigna, they want us to deliver virtual care. It's available like a visit. You're going to get the same time and attention. Heck, you might even get more, right? Let's market it for what it is. We are still using the office's time, effort, care resources, and systems to deliver care. You are a more captive audience than you have ever been. And I don't mean to say that to blame it on the payer, but let's bring this full circle right now to say that your insurance company and the current state of things in the pandemic, for my safety and yours, most importantly, yours and your family, Ms. Patient, this is how we do it, and it is a billable visit. We can say that gently, and the time to say it is now.
Great. All right. I have one more question. There are a bunch that came in lately, and we will get back to everybody via email later today or tomorrow. But the last question I wanted to ask you is, can you give an example of a scenario for using virtual check-in code and scenario for using a telephone-only encounter?
Oh, yeah, that's really great. So I think you heard me reference telephone only is great when we just can't connect on a patient's phone, right? They're tech challenged, we're tech challenged, the solution is failing, right? And look, we just, you know, maybe we're just throwing the EMR thing out the door. They can't get their camera or their audio on. Let's get back on the old school landline or phone only, right? That's a great opportunity for that. I think that's the only time you should do that instead of the audio visual E&M. That virtual check-in, I don't think it's seen as much utilization. I think you saw in reimbursement, it's not as great. If I'm trying to think about kind of a clinical vignette to give you around that, I envision someone that is just heavily dependent on the portal, that loves messaging you that way, where you can bill for that time of maybe a chronic condition. And if somebody wants to send me some other examples that I could share in kind back with the group in our, you know, some of our follow-up communication, I'd be glad to share it. But quite honestly, the utilization there is a little more limited. And I think it's become more limited as they've opened other options. And I don't say that just because I don't have a fantastic example or seven. But the virtual check-in is really for that person that is just like a portal evangelist that you're doing care for. And honestly, I think that can be a little harder to sell as billable versus a telehealth encounter or a phone only. Just kind of tying that back to the prior question.
Great. Thank you very much, Robin. And thank you, everybody in attendance. Once again, I apologize for some of the sound issues we had in the beginning. I hope we were able to fix that for everybody to be able to hear. If you have more questions, we are here available. You can reach out to Chirpy Bird through their email, or you can reach MIPS Pro and HealthMonix. If you go to mipspro.com, you can learn about all of the measures that you need for telehealth and telemedicine, as well as sign up for our future engagements. Everybody have a wonderful rest of the week, and we will talk with you again real soon. Have a good day. Thank you, Robin, and Joy at Chirpy Bird.